Very much. My name is Dapo, Ogunbayo. I'm a PhD student at the Manchester Pharmacy School. So I'm in my third year now, and I've got just like a year left on my PhD. I'm a pharmacist by background. I've also got a background in public health as well. So that's why I'm looking at sort of like pharmaceutical public health. So I'll be talking to you today about my PhD research, a part of it, which is exploring the contribution of community pharmacy in self-care support of long-term conditions. And I'm being supervised by Ellen, Chris, and Peter. They're all from the Manchester Pharmacy School. Yeah. So the talk is just 10 minutes. So I'll just go through bits of my PhD research. So I'll talk to you about. I'll just give you a brief background about long-term conditions and the concept of self-care support. Then I'll talk about my research aims and objectives, my methods and my results, and then sort of my ongoing and future work. I wouldn't bother you too much about long-term conditions, but just to talk about the broadening of long-term conditions here. Diabetes, cardiovascular diseases, chronic diseases, and chronic respiratory diseases and cancers are the leading causes of mortality and morbidity worldwide. In the UK in 2008, about 80% of all deaths were due to long-term conditions. And the prevalence of long-term conditions is increasing rapidly. So at the moment, there are about 18 million people with at least one long-term condition here in the UK. And this is projected to double just in the next 15 years. So it's a huge challenge. And the increasing prevalence of long-term conditions is due to changing population demographics. So we have more older people in the population. And this might be due to advancing medical technology that keeps people living longer. And it could also be due to increasing exposure to behavioral risk factors, such as smoking, alcohol consumption, physical inactivity, and unhealthy diet. So basically just bad behaviors, bad habits. Managing long-term conditions has always been a challenge to health systems. And, at the moment, there's a growing recognition that the current medical model of managing long-term conditions cannot meet the needs of the population. So the way things are set up at the moment, if things remain the way they are, it's not going to meet the needs of people with long-term conditions in the next 15 years. And because of this, there's been within the last 20, 25 years, there's been an emergence of sort of different models and frameworks and strategies for dealing with long-term conditions, for managing long-term conditions. The most popular one perhaps is the chronic care model, which was developed in the USA by Whiteman and his colleagues. And there's also the NHS and social care long-term conditions model, which is sort of like the Department of Health model and framework for long-term conditions. And then there is the chronic disease self-management program, which was also developed in the US. And it's more of a lay-led model for managing long-term conditions. And then there is also the medications therapy management, which is also from the USA. So there's quite a lot of models that are being developed abroad. But one of the things about so many of these models, including the ones from Australia, the ones from the UK, is that they have a philosophy which sort of like, it's more about changing the healthcare professional-patient relationship. So putting patients at the center of their health and care. So it's moving from that paternalistic approach to managing long-term conditions to the more patient-centered care approach. Now, self-care support it's emerged as a sort of like a distinct model, a distinct approach to managing long-term conditions. And this chart here, this diagram here, sorry. So yeah, this is sort of like the 3 tiers of care, which was proposed by the Department of Health. So it's just to let us know that the majority of people with long-term conditions require self-care at some point in their lives. And this proportion is about 70 to 80% of people with long-term conditions. Okay, case management is usually for those with high-risk patients in tertiary care, people with cancers, people with severe diabetes and multi-morbidities. While disease management is for high to medium risk patients based in tertiary and secondary care as well. So self-care support is for low-risk patients who are the majority of people with long-term conditions in primary care. So self-care support, it's also referred to as self-management and self-management support, depending on who the authors are. But it's simply, self-care simply refers to the care of oneself, so how we take care of ourselves, the activities we do and the behaviors we do that affect our health. So self-care could also be not doing anything, and also be referred to as self-care. The fact that you're not feeling too well and you don't do anything, that's sort of some levels of self-care. But for people with long-term conditions, it can be really complex and confusing. Because they have to take their medications, they have to change their lifestyles, they have to make appointments for their blood tests, and so many things. So it can be really quite confusing for people with long-term conditions. So self-care support has emerged as a systematic and coordinated array of activities that enable people to achieve self-care. It can be led, so meaning that self-care support can be led by other peers or people with long-term conditions. It could be healthcare professional-led, and this is sort of the area I'm focusing on because it's now, self-care support by healthcare professionals is now a key priority for the becoming about the UK. So at the moment, community pharmacy, they are healthcare professionals in primary care, but they're not yet fully engaged in the whole self-care and self-care support agenda. And this was exposed obviously during the early literature review at the beginning of my PhD. So current services, current activities that relate to self-care support in community pharmacy are more centered around the products, around the medicines. They are fragmented and they are service focused. So the question I tried to answer at the beginning of my PhD was, is there an opportunity for community pharmacy to play a major role in self-care support? So this leads on to my aim and objectives. So the overall aim of my PhD program of work was to explore the place, so where those community pharmacies stand, what's their place in the whole self-care agenda and their contributions as well. And the objectives of this part of my research was to explore how self-care support is conceptualized and applied in community pharmacy practice. Okay, so how do they understand what self-care support is and how do they put it into practice in their day-to-day activities? And the other objective is to identify and examine the components of self-care support that are applicable to community pharmacy practice. So in order to achieve, before I went on to do my study, I did some preliminary work, which was like mapping the literature, trying to find out what exactly, where is the self-care and where is community pharmacy in the self-care agenda. So I searched some few databases, but eventually I found that there was like a dearth of published material on self-care support in community pharmacy. So most of the materials out there were more around medication adherence, things around medications reviews and medication management. In terms of the concept of self-care support itself, there was very, very little published material around that. So most of the published material around self-care support, self-management support were, they were abundant in other disciplines, particularly in nursing, in medicine, and sociology. So what I found out was that self-care as a concept was like a holistic, multi-dimensional concept in patient-centered care. And medication management, which is sort of the area that pharmacists focus on, is just one dimension of self-care support. So during this process of mapping the literature, I came up with a sort of like a conceptual framework for self-care support in community pharmacy, which I will share with you a bit. So I went on to design a study, which is, which took the bulk of my PhD time, and so I designed a mixed method study using what I call the exploratory sequential design. So basically, I start with a qualitative phase, which is because the area is not well known. There's so many things that is not well known in that area. So I started with the qualitative phase, did my data collection, which was more about interviews, did the analysis, and this led to the development of sort of like a survey instrument, which I'm at that stage right now where I'm going on to the quantitative phase, which is about doing the survey. And the philosophical opinion of my research is more like pragmatism, so combining both the constructivist view and the other philosophy of quantitative research, and putting it together. So the qualitative strand of my study, which, like I said, is the major part of my PhD work, was set in England and Scotland. So I decided to examine, the views of pharmacists in both countries, in England and Scotland. And the reason for this was because the way community pharmacy is set up in Scotland is slightly different from the way it's set up in England. Yeah. So they've got some services which are focused on chronic medications in Scotland, which does not exist here in England. So we thought it would be important to try and see these differences affected the views of participants. So at the onset of my PhD, I set out to interview community pharmacists, people with long-term conditions, as well as other healthcare professionals, who are part of the larger multidisciplinary team. But eventually, we now decided to shelve the interviews with the healthcare professionals, with GPs and nurses, due to some logistic reasons. So, for this presentation here, it's more about my interviews with pharmacists. That's what I'm presenting here. So I went about identifying my participants using positive sampling. So I used a strategy called the maximum observation sampling. It was face-to-face interviews, which lasted between 25 to something minutes, and conducted between January and April 2013. All interviews were audio transcribed. They were audio recorded, transcribed. And I went about my analysis using the IP, which is the Interpretative Phenomenological Analysis. And I had to go through the NHS Research Ethics Committee to get permission for the research. So this is just the demography of my participants. So in all, I interviewed 24 pharmacists, 12 in England, 12 in Scotland. The number I came about is just because in qualitative research it's quite hard to have to get a particular number of people to interview. But I decided to go for 24 until I got data saturation, and that was when I got data saturation. Was after I did 24 interviews. There's really not much to talk about in the demography. Just to state that it was maximal variation, so meaning that I went out possibly to talk to different pharmacists in terms of their age, gender, ethnicity, pharmacy type, as well as their roles within the pharmacy. So with regards to my results, the way we present qualitative research is usually by presenting quotes. But I just thought because of the length of this presentation, just to sort of like highlight the key findings from my interviews. So one of the first things was that despite the differences in the contracted services in community pharmacy in both countries, in England and Scotland, there were no significant differences in their views with regards to self-care and self-care support as a concept. Okay, so these are just the sort of like different services provided in both countries, in England and Scotland. I'll come back to that in a bit. So with regards to the key findings, one of the things I found was that the current models of supporting people in community pharmacy is actually fragmented and it's service focused. So meaning that the ways pharmacists interact with people with long-term conditions were determined by the services. So it wasn't about going out to help patients, it was more about the services they are providing to patients. So if patients are not signed up for certain services, they don't get any interaction with pharmacists. And these services were mainly the medicines used, the new medicine service and the chronic medication service consultation in Scotland. And their interactions were often very brief and minimal. And despite the changes, so there have been a lot of changes trying to get pharmacists to be more patient-facing. But despite these, their contact with patients was still very minimal. In terms of their understanding of self-care and self-care support, I found that pharmacists generally understood what the holistic concept of self-care was all about. So that they understood that it was about patients taking responsibility for their health and care. It was about patients becoming more knowledgeable and more independent of healthcare professionals. It was also about patients knowing how to safely and effectively use their medicines. But in terms of how they went about providing the support to patients, one of the key findings was that providing patients with information and advice about medicines and the use of medicines was the primary ways in which pharmacists supported self-care. So for them, that was all what self-care was about. And from the holistic points of self-care support, there's still quite a lot of things that pharmacists don't get in terms of the way they went about supporting self-care. And they also took an opportunistic approach to providing lifestyle information to patients. So they wouldn't go out to provide information, lifestyle information and advice to patients. It wasn't until patients came out to ask them for help before they provided this information. And then obviously I concluded that their approach was more product-centered rather than patient-centered. And finally, based on the synthesis of my qualitative interviews, together with what I found in the literature, I came up with sort of like a conceptual framework for self-care support in pharmacy. So this has sort of informed the next stage of my study, in which I'm doing a national survey of pharmacists. But basically the framework consists of 4 components, which is self-care information and advice, support networks, skills training and support, and technology. And then there is also the strategy, the implementation strategy, which is the collaborative care plan. So I'm using this model which was informed by my interviews as well as my literature to develop my the next stage of my study, which is just doing an interview of the national survey of pharmacists. So at the moment, I've also completed another set of interviews with patients, so with people that use community pharmacy people with long-term conditions. So I'm doing the ongoing work is to do the analysis of these interviews. So like I said, I'm doing the National Survey of Community Pharmacists, which the aim is to identify and examine the key concepts and elements of self-export of pharmacy. And I've got about 1,400 random sample of community pharmacists in Scotland, which I will be administering my survey instrument to. So at the moment, I'm awaiting the University Research Ethics approval. Then I've also gone through a number of publications to publish the findings of that. So, thank you very much.
Do you have any questions about that at all? So the first part of your research said you didn't find a significant difference between England and Wales and how they treat Scotland. Yeah. Was that what you were expecting, or were you expecting there to be a difference?
Well, I was expecting there to be a difference, and that was because of I didn't go into detail in terms of what the differences were in the contract, in the pharmacy contract in England and Scotland. But in Scotland, in 2010, they introduced a service called the chronic medication service, which is supposed to get pharmacists to interact more with patients. So I expected that there would be a difference in the views of pharmacists in England and Scotland, but I didn't find any difference. So which was quite interesting.
What kind of questions are you going to ask in the next phase of your interview?
Yeah, so I didn't go into detail about the framework which I came up with, but the questions I'll be asking are based on that framework, which is about the components and strategies of self-export and community pharmacy. So the questions I'll be asking are based on those, I don't know if you want to give you the reference or something like that, because it's quite complicated in terms of how I came up with the framework. Share that with you.
My experience in life is that if you try to do everything at once, failure is inevitable. So have you worked out a plan whereby this could be introduced slowly with dealing with one medical aspect at once?
Well, one of the things which we talked about at the beginning of the PhD was to either focus on a particular medical condition like maybe diabetes or asthma, but doing that, there's a challenge because people with long-term conditions have multiple mobilities. So someone has got diabetes, they've got heart conditions, they've got asthma, they've got so many things. So isolating the different medical conditions and focusing on it might not be the best in terms of being practical. So we thought about looking at long-term conditions as a whole rather than getting it divided into different conditions. So we didn't consider that.
I think for the sake of time, we'll move on to the next one. If you remind, we'll be able to ask some more questions at the end.